Is anesthesia for laser airway surgery. A laser which provides a source of focused, coherent light which is capable of transmitting intense energy to precise location. Each laser type acts upon a specific chromophore like water or hemoglobin that preferentially absorbs the laser light, resulting in heat, eventually in the destruction and cauterization of the tissue. Laser can ignite flammable materials present in the operating field like endotracheal tube, sponges, catheters, gas pieces, especially in the presence of oxygen. So concerns in laser airway surgery are, it is a shared airway procedure. So maintenance of patent airway, adequate ventilation, and to provide unobstructed view of structures in the surgical field is essential. There is a risk of aspiration, spasm, bronchospasm, and laryngospasm, airway edema, and injury are possible. Use of laser has its adverse effects like airway fire and adverse effects of laser plumes, burns, inhalational injury, eye injury, and cross infection in case of papilloma because of aerosolization during laser surgery. So our goal is to provide ventilation while keeping the surgical field maximally accessible and minimizing the laser related hazards. The safety measures and precautions are the ET tubes, the conventional ET tubes with an inflated cuff are vulnerable to mechanical damage and also ignitable. So laser resistant ET tubes should be used as a default as per ASA recommendation. They should have double cuffs and the cuffs are inflated with saline or any biocompatible dye like methylene blue, which provides safety and also which acts as a visual alert if the cuff ruptures. ET tubes were designed to have less inflammable materials. In case of eye injury, all the personnel present in the room must wear a wavelength specific protective eyeglasses to prevent the laser exposure and damage to cornea and the retina. Patient's eyes also should be covered with wet gauze pads and also laser resistant goggles. At the doors and windows, a signage indicating a laser usage should be placed on the outer face of all the doors, and windows should be covered with opaque coverings. Mask which you use should have high efficiency to protect from the smoke plumes as they contain fine microparticles which are capable of depositing in the lower airway and alveoli, which has the risk of affecting mucociliary clearance, interstitial pneumonitis, bronchiolitis, and which is mutagenic. Ventilation strategies used are, it can be a spontaneous ventilation technique, intermittent apnea technique, and jet ventilation. In case of spontaneous ventilation technique, patient is anesthetized, maintaining spontaneous ventilation, and oxygen is supplemented through a side port in the bronchoscope or a laryngoscope. It provides an unobstructed access to the surgical field, but here the ventilation cannot be assisted, airway is not protected, and cannot be used. So it can be used in a short procedure where there is less risk of bleeding and aspiration. Intermittent apnea technique, where the patient is intubated and extubated intermittently with the airway exposed to the suspension laryngoscopy. So patient is intubated with the laser resistant ET tube. The technique is same as the standard ET tube technician. Smallest acceptable tube should be chosen. When intubation, the patient should be hyperventilated and the ET tube is removed to allow for a period of apnea. Duration of apnea is individualized and it is determined by a pulse oximeter and the end-tidal carbon dioxide. SpO2 should be more than 90% and EtCO2 should be maintained between 40 to 60 millimeters of mercury. Additional continuous respiratory gas delivery via high flow nasal can be done to increase the apnea period. And inhalational anesthetics are better avoided, which leads to pollution, and also it does not provide adequate depth because of leakage. So TIVA is preferable when we use intermittent apnea technique. Anesthesiologists should have a spare ET airway devices readily in the same size and the size smaller in case of airway fire or ET tube is damaged. Jet ventilation technique, it utilizes a high pressure stream of gas delivered in the upper airway So there will be active insufflation of inhalational and gases. It can either supraglottically, transglottically, and transtracheal approach. Where the transtracheal and glottical approach helps in pushing out the blood and the debris during exhalation, where in the manual jet ventilation, it depends on the passive exhalation, so it requires a patent upper airway and adequate time for exhalation between the jet ventilations. High frequency jet ventilation, which delivers a very small tidal volume at a very high respiratory rate, especially 100 to 150 rates per minute. This can prevent the barotrauma and can prevent the disadvantage of manual jet ventilation, but it requires a specialized equipment, properly trained personnel, and IV anesthetic delivery technique. Blood gas monitoring is must if the procedure is prolonged in order to detect hypoxemia or hypercarbia during this technique. The disadvantages are mucosal dehydration, stomach insufflation, laser burn to the trachea, pneumothorax and pneumomediastinum with this technique. Other precautions include surgical team should use flame resistant surgical drapes, especially the wet gauzes and the wet cloths to cover the exposed parts. Plume scavenging system should be employed. Room suction hose nozzle inlet may be used, and it should be kept within 2 inches of the source of laser for effective scavenging. All the personnel should be appropriately trained in laser safety and should have performed a fire drill. Syringes with saline, large, at least 50 ml, can be pre-made in case of airway fire. Laser should be operated only by a personnel who is trained in it. In case of airway fire, whoever notices the fire first must announce it loud immediately. We should remove the fuel source like ET tube and the remaining fragments inside the airway. Remove the source of ignition, like stop the laser. Eliminate the oxidizer flow in case of oxygen is used. Disconnect the ventilator, stop ventilation, disconnect all the circuits, and extinguish the remaining fire. In order to continue IV anesthesia, and then mask ventilate the patient with 100% FiO2. Then do a check laryngoscopy or a bronchoscopy to look for any damage to the mucosa. Then re-establish the airway with the help of ET tube or LMA or tracheostomy if required. Consider ICU admission. In case if fire remains active, activate the fire alarm and the theatre should be evacuated. Consider steroids for anti-edema and antibiotics. To decrease the airway fire, we have to use the lowest oxygen concentration possible, which is less than 30%. Avoid nitrous. Use laser resistant equipments. Limit laser use to short pulses and the lower power. Activate the laser only when the tip is visible and the ET tube is out of reach of source. Cover the patient face and chest and every exposed part with wet towels and protect the eyes. Saline filled syringes should be pre-made, and we should know the nearest location of fire extinguisher and water sources. That's all, sir. Thank you, sir.
Okay. How do you classify airway surgeries? The question is laser airway surgeries, anesthetic management of laser airway surgery. So is there any classification of airway surgery which can be managed by the usage of laser? It can be supralaryngeal or subglottic, I mean supraglottic or subglottic. Okay? You can do it above the glottic level, or because the anesthetic technique will be slightly different if it is supraglottic and if it is subglottic. Supposing you have a growth in the one of the bronchus, main bronchus, right or left main bronchus, which you want to remove by laser. Can you do it without intubation?
No, sir.
Or with the jet ventilation or other techniques?
No, sir.
And there you have to use a bronchoscope, either a rigid bronchoscope or a flexible bronchoscope, which has to go through, and you have to identify the location of the tumor and knock it off with the laser. Okay, so you can classify them as supralaryngeal or supraglottic and infralaryngeal or infraglottic. And based on that only, you have to say all the methods of your anesthesia management. Okay. Otherwise, you have covered most of the points. I will do my presentation on that.